So now I'm just going to run quickly and practically through over a few pitfalls that clinicians tend to base themselves on, to base their neuromuscular monitoring on, but actually tend to lead to the wrong conclusions. And the first one I actually already addressed a little bit, and is the fact that clinicians or anesthesiologists tend never to see the true complications of residual paralysis. The most, what an anesthesiologist might tend to think as the biggest complication of residual paralysis might be a reintubation, but actually these sort of events are rather rare. Most of the more subtle complications actually happen after discharge from the postoperative anesthesia care unit. Something that we can, in fact, objectivate is that patients tend to be longer after post-anesthesia care units, and this is their discharge is delayed. Another common pitfall, which Dr. Camus has also touched, is the fact that some clinicians tend to base themselves on clinical signs to decide whether or not a patient is adequate to be extubated. This is quite frequent, but again, a big pitfall. For example, a normal tidal volume is possible between TOF ratios of 10 and 30%. And just because a patient is able to generate enough diaphragmatic force to produce a normal tidal volume does not mean that he will be able to maintain a patent airway when the tube is pulled out. So there's a bit of a disconnect between what clinicians think is adequate and what is actually adequate. Another also frequent, I will not put it as an excuse, but as an argument to extubate a patient without monitoring, is clinicians that state that their last dose of Rocuronium, for example, has been given a long time ago. In the graph below is an example of a patient that belonged to a study that we conducted, a practical study in which we just set to measure if the TOF ratios that we normally measure during clinical practice are similar to what is predicted by the best pharmacokinetic and pharmacodynamic models, and in this case only for Rocuronium. And here we have an example of a patient that at first sight does not have any elements that we think that might lead to a prolonged neuromuscular block. But what we see is that there's a big disconnect between what is predicted and what is actually the reality. Of course, not all patients are like this, but in approximately 200 patients that we studied, what we see that all in all, there tends to be a big disconnect between what is predicted and what is the reality, and sometimes up to 1 hour, 1.5 hours. And these are the models that we get taught when we are studying anesthesia, and that define common variables that we know, such as half time of a drug. These are static variables, but they tend to disregard a bit what is the intraoperative dynamics. So basically, the conclusion is there is too much variability. If we don't measure, we really don't know where we are. Another common pitfall is unmonitored antagonization. Dr. Camus has basically touched this also. Neostigmine needs to be given at the right moment, depending on the guidelines, at a TOF ratio more than 20 or 40%. Otherwise, there is a big variability in what would be the expected return to a normal TOF ratio. So just giving Neostigmine at the end of an operation without measuring the TOF ratio is also not adequate. Sugammadex, Dr. Camus also touched this topic. Residual paralysis is still possible if Sugammadex is given, and we don't know exactly at what depth of block a patient is. Certain patients, such as the elderly and obese, are actually at particular risk for getting recurrenized after Sugammadex. So it's something we need to focus on. Also, and this is very important, Sikomonics is not always the most cost-effective option. However, selective use of Sugammadex is. And below, I just show you a study that has been recently published this month in Anesthesia and Analgesia, in which the main author, also the main author of the ASA guidelines, set out to see if they would antagonize a patient based on the guidelines and quantitative neuromuscular monitoring, as opposed of just giving Sugammadex to everybody, what would be the cost difference? And actually what I observed is that there were savings of approximately 43% by just targeted antagonization instead of just using Sugammadex for every patient. So as you see, this might also cumulatively lead to some cost saving. So the bottom line is residual neuromuscular block is both prevalent and importantly a silent entity. We don't tend to see it on the immediate postoperative period. There are a lot of neuromuscular management myths, and these tend to be propagated peer-to-peer. So educational efforts are primordial to reduce this phenomenon. And the only way to consistently and reliably exclude paralysis is just by using quantitative monitors.